Yes, thank you very much. There may be a few questions in one sentence. First of all, I was very interested by the AfriNest study, but are we sure that we're dealing with the same thing as in many places? Yes, in our neonatal unit, some children, some neonates come late, like at 10 or 15 days old, but are we dealing with early sepsis in AfriNest or late sepsis, which
both.
makes both?
Both.
Okay, and there's another thing, if I may, regarding the rotation of antibiotics. I think it's very important, and the fact that also we don't have many data, and I think it's very urgent to have this data in terms of epidemiology of bugs that we have in Africa, which seems to be different from northern or developed countries. Klebsiella, as you mentioned in Haiti, and Staph aureus seems to be much higher level than any other places in northern places. So from the beginning, ampicillin genta is not the best for Klebsiella. So why did we do that in the first place?
So, Laurent, those are very important questions. They have to be answered from a public health lens as opposed to a hospital lens. So what we are trying to encourage people now, increasingly, is to not look at single hospital etiologies or single hospital antibiograms, but to look at the whole cluster, or what is it that you're dealing with in a community. Now, the knee-jerk reaction to any drug-resistant infection is, let's go on to the second line because we have to save lives. But we are dealing now with a situation where that knee-jerk reaction can rapidly lead to basically no antibiotic being effective. Now, I'll give you, I was sent a question by MSF from Peshawar just last week with antibiograms from 3 hospitals in Peshawar and making the case that perhaps we should be using vancomycin. Now, that would be the last thing that I would do, because you may do some benefit in the short term perhaps, but once you lose vancomycin, you've got nothing left. So Klebsiella is still not the worst kind of pathogen that you will see in some of these neonatal outbreaks. Wait till you see Serratia and wait till you get drug-resistant enterobacters. So what needs to be done in that circumstance is that get people together from facilities that are dealing with some of this, take care of some of the prevention side that Uli was talking about, and agree on a rotation of antibiotics, be those second line or whatever, preemptively over a period of time that releases some of the antibiotic pressure on pathogens. That's what's been tested and tried, and some of the best examples of antimicrobial influence by that kind of a practice are actually from Sweden. You know, if Otto Kars was here, he would tell you how for respiratory pathogens, that was what was done in this very country, and other people are waiting to follow. Maybe you have an answer to some of this from your own experience in Haiti.
Regarding the second line.
The antibiotic rotation.
Yeah, I think obviously it would have been ideal to agree with the other hospitals to have some kind of system. But there we were kind of one step behind. We were just sharing our experiences, and slowly they were realizing, oh, we might have problems too. But I think at that time we were not at the point yet to have to agree on a system on second-line antibiotics, but obviously that should be the aim, yeah.
Any other questions?
Irène Adeossi, je viens du Niger. Que pensez-vous de l'utilisation du gel en chlorhexidine dans un contexte où 2/3 des enfants, des accouchements se passent à domicile sans assistance? Ça, c'est la première question. La deuxième, c'est par rapport à la stratégie SONU, soins obstétricaux néonataux d'urgence. Qu'en pensez-vous? Merci.
Is there somebody who can translate? Uli, can you translate it?
The first question was regarding chlorhexidine as a disinfectant in a setting where the birth is not in a medical facility. Like,
yeah.
What's your opinion?
So that's the WHO recommendation, that if you are dealing with births that are taking place in a very unclean environment where the risk of colonization and infection is very high, then it is a very effective preventive strategy. On the other hand, with these data from these 2 trials in Africa that have come out now, where a large proportion of births were in hospital, you don't see the mortality benefit of chlorhexidine. You see some benefit of reduction in omphalitis, but doesn't translate into a mortality benefit. And that is common sense, that if you were dealing with a birth in Stockholm today, then you wouldn't have, in a very clean environment with the use of clean birth kits, any added value to adding chlorhexidine. So yes, it's for community births right now.
And the second part of the question? Can you
La
maybe
seconde
repeat it?
question, c'est par rapport à la stratégie soins obstétricaux et néonataux d'urgence. Chez nous, l'évaluation n'a pas été très concluante. Qu'est-ce qu'il en pense aujourd'hui? C'est un mythe ou une réalité?
If I understand correctly, what is your recommendation regarding the obstetric neonatal care, the link between?
Thank you. That's a great question. And that's what I do. So at the Aga Khan University, I was at one stage the chair of pediatrics. We changed the department. We made it the Division of Women and Child Health. We combined our departments of pediatrics and obstetrics gynecology. And we even created a perinatal, neonatal group in between. So I think to answer your question practically, even if you don't have common controls or common programs of women and child health, you need to have a strategy, certainly for bringing the maternal care and newborn care together, which means that practitioners have to sit together and come up with agreed protocols, agreed way of doing this. The neonatal intensive care unit is one place where obstetricians and pediatricians generally come together, because that frequently is where the products of pregnancy are generally admitted if they have problems. But you have to, depending upon which facility you are in, and it's easier to do it in smaller hospitals than in large university hospitals, but you have to come up with the concept of teamwork, perinatal teams, where people involved in maternal care, people involved in perinatal care can come together, plan and work together. It's sometimes not very easy, but increasingly there is greater recognition that that's how it needs to be done. In Toronto, the neonatologists work hands in glove with the obstetricians in the facilities which are dealing with mothers and babies.
Question over there, and then.
Yeah, I would really like to support you in this. I'm from Karolinska, and we had a randomized control trial published 6 years ago about this family-centered, where we actually could randomize 380 families, either to conventional care or to where the families could stay 24/7. And even in these high technical setting or resource setting, we found an amazing result, and that we actually had a reduction of length of stay during the intensive care period. In the babies that were below 32 weeks, we reduced the length of stay with 10 days. And those 10 days were when the babies were in the intensive care area, not in the skin-to-skin rooms or family rooms. And we also had a tendency of lower infection, but our infection rates were only 5%, so we didn't reach statistical significance. And the thing is that we now developed here at Karolinska is what we call couplet care. And that is, we couple the care of the mother with the care of the infant that has to be admitted to the NICU. So the mother can be non-separated. Of course, if she needs intensive care, we cannot do that in the neonatal intensive care unit. But as soon as she's off intensive care, you roll the mothers in their beds, and they could stay 24/7 in the NICU. And we have midwives taking care of them and obstetricians doing rounds. And I think that's exactly what we need to do. And also I support you that, or I think this study that Niels mentioned, the immediate skin-to-skin, would be very interesting to see the results, because what we want to do there is to see the effect if we have non-separation from the very start, even when the infants are unstable. And if we can expand our NICUs in floor-wise and in square meters, we can have beds, as we saw pictures from Uppsala, where they could stay in the intensive care unit, and they could do more and more of the care, and we have less hands on the babies, fewer external germs. So, yeah.
Question over there.
Hi, I'm Matt Coldiron. I work at Epicentre. I have an observation, and I maybe just have your reaction to it. MSF is a medical humanitarian organization, so we want to provide good quality medical care. I think in some fields we also do a lot of prevention, vaccination, water and sanitation, things like that. But in my experience, one of the places that we're a bit reticent to do some preventive measures is especially with things like safe birth kits. I think the rationale sometimes is, well, we want women to give birth in a facility. And if we give something like a safe birth kit to them, that's going to give them an excuse, but they're not going to come if we give them a safe birth kit. I have differing opinions on that. I go back and forth one day to the next. But I think it's a point of tension, and I'm just curious what you think about that.
So so that's a great question, and I have to be very careful in the way I answer it, because MSF is a fantastic organization. I mean, it's an organization which is unique, and I think a lot of what you do is based on experience and based on what you believe in and do. But I also believe very strongly that the whole point in doing evidence-based practice is that you try and always improve and bring best practices in. One of the things that any humanitarian organization, this is not just meant for MSF, have to do is in any situation where you go, don't necessarily take a short-term view. So wherever your facilities are, wherever your services are, you have to have a population-based or a community-based objective. If you don't have it, then most of what you will do is not sustainable. And you will lose the effect of it when you leave, when you move. And everybody moves. I mean, MSF does not have the permanence of having something in a place forever. So I think the importance of 3-4 things in those circumstances are to be underscored. One is very close linkage with the public health program, whatever shape and size public sector program, so that whatever you're doing can inform it and can be informed by it. Secondly, a population-based approach. So things like preventive strategies that don't fall into the humanitarian umbrella can still be incorporated by a variety of means available to you, advocacy, by outreach, etc. Third, very importantly, reducing the burden of the problem before it occurs. So I think this whole, I've heard this expressed several times before also. You're talking in the concept of birth kits. I've had pushback from humanitarian organizations saying that it is not our responsibility to be dealing with wash, clean water, sanitation, hygiene, and they say someone else's responsibility. Yet they're dealing with kids dying with diarrhea and cholera day in and day out. And we all saw this in Haiti. You know, when the cholera outbreak occurred, how many people were involved in just saving lives in facilities without stepping out with all of their knowledge to say, what the heck, we have to be doing something about preventing these cases from taking place in the first place. So I think there is this element of having a balance of preventive, promotion, and treatment, which, although difficult, but has to be done. And finally, as I've heard again today, several times, there has to be monitoring and evaluation, not just in terms of process indicators, but also in terms of your own learning from things. So I think in any organization, be it humanitarian, be it an academic organization or otherwise, learning from doing and improving your practices based on sound approaches. I'm not using the research word, but sound approaches which are based on monitoring, evaluation, and accountability, to me is the best form of research. And there ought to be that process of learning within an organization like MSF. Oh, I can see that I stirred things up. I'm sorry.
No, I just want to follow up from that question, because I think we all agree that this is the prevention and reaching out to the community and thinking about what is happening around our health facility per se is incredibly important. We all know MSF is there sometimes for a few months, sometimes for a few years, and very often for a lot longer than we intended to be there. I'm not sure how many organizations are there for a very, very long term. So sustainability is important, but it cannot be the only dictating factor. But my question to you is back to what Matthew was saying. Our fear, or some of our fears linked to distributing birthing kits, is not that we don't want to prevent what's happening in the community. We are afraid of deterring women from coming to health facilities where birth could happen with skilled assistance. And that is, I think, the conundrum we're finding ourselves in sometimes. That is the question. It's not about, philosophically, whether we're in favor or not in favor of working with wash or non-wash. I think we would all agree we would like and we should be doing more of that. Thank you.
So I can assure you on that count, because that's a question that's been very effectively studied in depth in these global evaluations of clean birth kits, and particularly in the cluster randomized trials. So in our own studies, and we've published 3 large cluster randomized trials on this, we have never seen, with the right messaging, an adverse effect of clean birth kit availability and distribution on facility births. Doesn't happen. And in this Cochrane review that my team has just very recently updated on the use of community health workers in terms of promotion and community outreach, the impact in terms of referrals and skilled attendance is positive. So I think that's perhaps depends upon how you message and how you get them out, but it is not the experience from large, well-done programs with community health workers and clean birth kit distribution.
Yeah, just to add in an example from an MSF project in Chhattisgarh, India too. There we had the practice to give out birthing kits. This was integrated in the prenatal consultation, and the women were informed about warning signs and red flags. So basically they were told if everything goes fine, it's fine, go ahead with your traditional birth attendant and the birthing kit. If you encounter these problems, then rather organize transport and come into the hospital as soon as possible. So those 2 strategies were combined, and I had the impression that the women were not, we didn't prevent them from coming to the hospital. We rather encouraged by giving the birthing kit.
Anya? Oh, sorry, over there.
Thank you.
And then you.
My English is not so good, so I think it's better for me and for you to ask my question in French. J'ai 3 questions que je vais essayer de faire court. Premièrement, dans l'expérience d'Haïti que j'ai trouvée très intéressante, il m'a semblé que les enfants en soins kangourous étaient 100% colonisés par des germes multirésistants. Comment l'expliquez-vous? Est-ce que vous avez regardé ce qui se passait dans les salles d'accouchement? Et est-ce que ce n'était pas là l'origine de ces infections, en tout cas de ces colonisations nosocomiales? Deuxième question.
Maybe I can go ahead with the first one.
Okay.
Otherwise it will be difficult. So the question was basically, he observed in our statistics that the babies in the kangaroo mother care unit were colonized with Klebsiella, ESBL, pneumonia at 100%, which I can confirm, and it was more or less the same situation in all, like in the beginning of the prevalence screening, at the end, like there was some time period when the colonization rate came down a little bit, but still, as you observed correctly, the colonization rate in the kangaroo mother care unit was very high. And then your question was basically if we looked into the delivery room and if maybe colonization might have happened there already and then was carried on into the kangaroo mother care. There I can reply that we did screenings all over the whole hospital. the OT, the triage area where the women were admitted, the delivery room, and the pre- and postnatal ward, and also one ward where the moms were staying, the moms who were already stable were staying just to be close to their kids. There was also one separate area. I didn't show all these results, but basically the results showed that in all other areas of the hospital, despite the only leaving out the pediatric ward, the colonization was very, very low and almost zero. It was really focused on the pediatric ward. And the explanation we came up with, I'm not 100% sure if it's correct, but all our babies who came to the kangaroo mother care have already been in intensive care and in intermediate care for days up to weeks. Because in Haiti we had the unfortunate setting that the mom couldn't be with the baby from the very beginning because also the moms were just too sick. So most moms spent a few days in intensive care because they came in unconscious or convulsing. So obviously there could be something improved on a logistical level, that the moms could see their babies and stay with the babies earlier. But practical, there were also some medical limitations because the moms were simply not conscious and not medical stable. So basically all babies arrive in the kangaroo mother care unit had a minimum already of 1 to 2 weeks hospital stay. So our explanation was rather that the baby was probably colonized in the pediatric department and then moved on towards the kangaroo mother care unit with its colonization. Because in the term babies, or the babies doing fine, born in the delivery room by vaginal delivery, as far as I remember, there was like zero colonization. So it was really the preterms having a long hospital stay being colonized afterwards.
Thank you. Second question. J'ai été confronté au problème des infections nosocomiales pendant de nombreuses années en Afrique, maintenant à Madagascar. Et à Dakar, on a presque réussi à réduire, à faire presque disparaître ces infections avec un package. Et dans ce package, il y avait une politique des antibiotiques, des risques infectieux. Et donc, je voudrais avoir votre opinion là-dessus. Vous n'avez pas du tout parlé dans la lutte contre les infections nosocomiales de cette prévention par une réduction de l'utilisation des antibiotiques dans les risques infectieux. Et je voulais avoir un petit peu votre opinion là-dessus.
And he would be interested in getting to know your opinion about antibiotic treatment based on
As I want to know your opinion, because they implement in Dakar a policy to decrease antibiotic use when it's just neonatal suspicion of infection based on maternal risk.
Okay, so I think this is a subject of a longer discussion. I mean, there are certain maternal risks where you would start an antibiotic depending upon the newborn situation, particularly if they are premature, and others where you can afford to wait 24 hours or so. As I said, in preterm premature rupture of membranes, mothers should receive antibiotics. But in premature rupture of membranes, which are in term babies, there is no evidence that giving antibiotics makes any difference. Similarly, in newborn infants, what WHO has now done, and I would really, I'll be very happy to send you the papers, is to very systematically look at the combination of clinical features that are associated with the highest sensitivity and specificity for culture-proven infections that all of us as practicing pediatricians want to know. But those combination of features are very interesting because, number one, they show that fast breathing on its own, alone, does not necessarily suggest infection. But a combination of other things, such as reluctance to feed, such as temperature instability, recessions in their respirations, are associated with higher risk of bacterial infections. And in those circumstances, I think it would be very risky not to give antibiotics. So the one good news for all of you is in this doom and gloom of antimicrobial resistance, the global epidemiology of AMR does indicate that eventually drug resistance is associated with lesser longevity in some of these pathogens. So drug resistance patterns don't stay on forever. These bugs burn out. So almost every outbreak that I've been associated with severe multi-drug resistant pathogen has eventually died out. But they die out a little faster if you have preventive and promotive measures. But don't change your antibiotic policies for a very long period of time without reverting back to what might be, let's say, first line, second line regimen. So what shouldn't happen, and I remember in one instance we changed over to monobactams for 6 months because we had no alternative at that time. We had a multi-drug resistant Enterobacter outbreak, but we then stopped that and reverted back to original regimen. And what happens is when antibiotic pressure goes down, these pathogens do revert back to their original sensitivity.
Anya has a question over there.
Thank you. Yes, again, much more of a comment. Just listening about newborn care all day long now today, it's, again, I think the impression we have to do the basics right to really save lives, and this is the way how we can save lives. So it's, again, a call of all you people here in the room who would take care of us doing the pediatric projects. In most of these projects, we don't have pediatricians, again. So also in all the strategies we put in place, we need to think of how we can stop our colleagues and our staff being frightened of a septic baby, because that is a frightening situation. And you don't want to stand there. So we really have to have in mind directly, not only the medical part of it, but how do we really strengthen our staff and our colleagues who really can't sleep at night because they're afraid of losing these kids as much as we do. We just have probably better strategies how to deal with it. Thanks.
Thank you. Maybe one last remark, question. I think your neighbor had a question or not? Not anymore. Then maybe I'd like to wrap up by saying that MSF can do a lot in prevention. I think all the preventive measures you have mentioned, they are very valid. They are not very expensive, but sometimes they will be difficult to roll out. I think it sounds pretty simple and it sounds very logical, but to really get everything there sometimes is a challenge, and especially in a situation wherein we work in insecure contexts, doing this prevention well is sometimes not easy, but I think it is something we should focus on, and we should try harder to get there. A second thing is that what I found very interesting is the discussion or the presentation that Anne Pité gave this morning about the reduction in neonatal mortality in grouping neonates. But then on the other hand, the example of the Haiti setting where we group a lot of neonates and advance our care a lot, where we get a lot of problems there with antimicrobial resistance. And then there seems to be some kind of a balance in our level of care. We should advance, but maybe we should advance our IPC measures before we enhance our treatment options. And then where is that balance? And I think that is something we in MSF struggle with. We want to proceed, we want to get better, but sometimes we do not exactly know how and what are the best steps.
So if I may make a comment, so I mean, I'm actually fascinated by some of the discussions that you're having. There is an acute, urgent, global need for looking at best practices, evidence-based best practices in settings of humanitarian emergencies and getting some of that typology right, because one emergency is different from another emergency. You know, acute conflict is different from chronic fragile situations, different from acute, you know, natural disasters. And at the moment, some of us who are in the middle of this are quite challenged by the diversity of opinion and the lack of very clear evidence-based synthesis and guidance. And that evidence-based and synthesis doesn't have to come from randomized controlled trials. It has to come from also a lot of experience in countries and by agencies, organizations such as MSF and others. But it has to be done as a global community together. So before I came here, as some of you know, we have initiated a global exercise by bringing various agencies together to see if over the next year, year and a half, we can get to a situation where the questions that you are asking, what is the best strategy? Should we be grouping newborns together? Should we be promoting a mother-baby dyad? Should we be doing a lot more outreach and outpatient ambulatory therapy as opposed to keeping babies in hospital? What is the risk-benefit in various situations, and what works? I mean, those kind of things can be handled as a global community. So I think this is a phenomenal opportunity for us to do well, and we would like to extend an open invitation to MSF to be part of this global discourse. It will take us a year and a half, 2 years to get it done, not just for maternal newborn, but also for child, for adolescent, for mental health. I mean, these things are very opinion-based right now. They are not evidence-based. And the last revisions of the Sphere manual that I've gone through in extensive detail over the last 1 year do not bear a relationship where the global evidence has gone. Even something like chlorhexidine use in the right circumstance, you will not find that mentioned in there. There is so much work going on putting neonatal kits together in the hands of frontline health workers so they can have access to the tools that they can use in circumstances where they don't have access to neonatal intensive care units. I mean, that evidence also needs to come into some of the field manuals that our staff have. So I'd really welcome your comments. I think there is a need for us to work together, and there is an open invitation to MSF to be part of that movement.
Thank you very much. I think that is a nice end of the session, and I think we'll take you up on your offer. Thank you very much, Uli.